A very good afternoon to one and all. I'm Dr. Uttara Mohan from IP Digital Media team. We are live on YouTube for this webinar. The topic for the webinar is the hidden burden, pelvic floor health in aging women. The speaker for today is Dr. Jasmine Flora. We are live on IP India YouTube channel. I request all to subscribe to this channel to get regular notifications of live webinar. You can also follow updates of our upcoming activities of IAP on social media platforms such as Facebook, Instagram, Twitter, and LinkedIn. I'll be sharing the links for the social media profiles in the chat. This webinar is being organized by IAP Women's Cell Tamil Nadu. The moderator for today is Dr. Vijay Bharti. Now I request Dr. Vijay Bharti to please take over.
Very good afternoon to everyone. We welcome you all to the first day of our webinar series, IAP Women's Health Tamil Nadu. It's proud to welcome the World Physiotherapy Day 2025 with our eminent speakers share their knowledge continuously with us for the next 8 days. We feel perfect to start with the topic related to women's health today. It's our pleasure to welcome Dr. Jasmine Flora ma'am to deliver today's topic. She is a MPT OBG PhD research scholar, assistant professor, guest faculty at Garden City University and NUPO University, Bangalore, women's health and pelvic floor physiotherapist at Sugat Heart and Women's Wellness Clinic, Bangalore, APTA accredited dialysis recti and postpartum core rehab specialist, Canada, certified lactation and IOCF counselor, BPNI, certified diabetes educator, YMCA Vellore, 18 years of experience, 5 years, 13 years as clinician, 5 years as academician, resource person for conference and workshop, associate member of PCOS Society of India, life member of Neurogynecology Pelvic Floor Dysfunction and Incontinence Association, Hyderabad, life member of Female Pelvic Pain Association, member of Indian Association of Physiotherapists, author in IAP Book of Clinical Guidelines for Women's Health Pelvic Floor, Part 1. On behalf of Women's Health, IAP Women's Health, Tamil Nadu, we extend our warm welcome to you, ma'am.
Thank you, ma'am. Good afternoon. Thank you for the warm welcome, ma'am.
Thank you, ma'am.
Shall I continue, ma'am, or is there any introduction session for anything?
No, ma'am, you can continue.
Okay. So good afternoon to everyone who were joined the session. I warmly, my grateful thanks to everyone who were in the IAP team as well as in Tamil Nadu IAP Women's Cell team also. It's my great pleasure to be part of this webinar series and it's always pleasure to share about the women's health, especially in this topic because it is most inevitable topic and it is necessary to be understood by the patients as well as by the physiotherapists. So we'll start the session today. I'll just share the screen. So today's topic is actually the hidden burden, pelvic floor health in aging women. So why I have specified as hidden burden is always it is underreported. When you see the data, so I'll be giving the data statistics regarding the pelvic floor health as well as the dysfunction, it is always the incident rate will be shown very less. But when you see in the clinical side or when you just inquire with the women, it will be more in number. So it is underreported because of the embarrassment and the shamefulness that women is experiencing, and also they couldn't even carry over these kind of symptoms also. So it is always a unspoken hidden burden for every woman who cross the 30 years of age. I even seen in my clinical practice, I was seeing the 20 plus year women also having this, they couldn't even express to their mother. So it is always been not only in the aging women, but it starts from the late 20s and it is more significant in the 40 plus, and it's going to be a crucial act in the 60 plus women. So that's why I have written as hidden burden, and we have to know, and I have given the subtitle as breaking the silence and restoring the dignity. So it is not the topic of incontinence or the prolapse, but how to improvise or empower the womanhood in overcoming all these issues and regulating a healthy and happy womanhood. That's why I have given. So we have to, this webinar or this aspects what we are learning today will make a step forward towards to break the silence and have to speak about to the patient to make them open up what they are undergoing and make them to seek the correct treatment as well as the advice from us. So that's why I have given the hidden burden and restoring the dignity. It's not only regaining the function, but it gives a promised happiness to the women also. So that's why it is more important, especially in the aging period. So what we are going to learn today. So just we are as a physiotherapist, students or clinicians, we have been more into the many aspects of women as we are also a women. So we know all the process and the stages what we are undergoing and we have learned in books in many things. But I always like to teach out of the box. So aging in women. So how it is happening in the women, it is same as the other fellows or how it is prevalent in India, especially in South side. And next one, how this aging is having an impact in the pelvic floor. See, everyone knows menopause and other things going to impact the pelvic floor. But what is the exact mechanism? And what are the impacts that you can see in the pelvic floor because of aging? And how the symptoms is having to impact in their day-to-day lives? And how we can screening. Many investigations are there. We can assess through the assessment scales and questionnaire and also urodynamics. Many things are there, but out of that, how you can make the patient to speak up and bring out the condition what they are having, what the problem they are having, and how we can detect earlier, and how we can prevent these conditions once they start earlier in the 30 plus itself. And I'm going to outline the management, what we are providing now and also updated, and how we can prevent these issues in the aging women. So that's the things we are going to discuss today. We'll so one by one. So actually, what is aging in women? So always knows 40 plus, 50 plus. By I always, the aging is beginning from the late 25 itself for a women. When you see each and every aspect, you can see it actually starts from the late 20s and it picks up in the 40 to 50 and almost 60 plus only everyone will start to realize it. So we'll see about the insights of the aging in women. So what is mean by aging? Is it any pathological related or anything condition wise? No. It is a time related deterioration of the physiological function necessary for the survival and fertility. So this, it is a time related because it is always quoted with the age. So it is always a time related, just a backward of going of all the normal function. So some things are visible to us, the graying of hair and the skin is getting the aging process and other things, the tiredness and everything we are able to feel. And something about the pelvic floor is always unspoken. It is hidden. We cannot even easily diagnose or easily understand that this is also a step of a aging process. And what we are seeing as aging is not a abnormal pattern. It is not a diseases of the aging, but it is the characteristics of aging. It is distinguished from the other diseases that happens in the aging. So whatever things I have given here, so at the down, I'll be giving the blog or the article so that you can refer it later. Okay. So how the World Health Organization differs the healthy aging, which is the main theme of the World PT Day. The process of developing and maintaining the functional ability. It is not the getting away from all the diseases, but it is maintaining the functional ability. That's what I see. We cannot recover anything structural. We cannot slim down more or we cannot go back to the young stage as we are in the teens to young adults. But we have to have the functional role, functional capacity equal to the 20s. Though we may be in 50s, but our functional capacity to be equivalent to give tug of war to the adolescents, and that enables the well-being in older age. So when you are improving the functional ability, it gives a good well-being in the older age. So here we can see there are a lot of different pattern of age groups in women. So we can speak about, I always say aging begins in the 20 later age. So usually when you see in even single aspects of the women's structure and the physiological function, when you see it starts in the late 20s, when you think about the ovary or the eggs or the uterus, it significantly starts at 30 plus beginning and it's pick up in the 40 to 50. So I have given the statistics of India, how the aging things is happening. So they are saying India is growing rapidly in aging. So aging population is higher. So we have to think about the health well-being of the aging population is very important. And I have given the outline. So many conditions are happening to the aging women. So that affect uniquely only to the women or disproportionately it will affect the women or it may affect women differently from men. So I have given a classification. So when we take this pelvic floor, it is going to be always affect women uniquely. It also happens in men, but it's going to be affect the women in a higher rate, and it's going to be affect her personal life, social well-being, everything. So that's why I can say it affects women uniquely. So next we are going, so we have seen the aging, healthy aging, and how this pelvic floor dysfunction is affecting this aging population. We'll see some of the statistics, what's happening exactly. So 1 in 3 women, so the incidence is very higher. Every women who undergo the childbirth, or sometimes the any structural deformity is there. Structural deformity is congenital defect in the structure of the pelvic floor or the organs that also lead to the dysfunction. So it get more suffer in silence. That's why the data is very less because of the underreported. And that's another thing is many women normalize the symptom. They feel that I'm aged, so that's why I'm having this. So as a part of aging, and don't seek medical care, when they will, most of the patient who comes and seek treatment for the pelvic floor dysfunction is they are coming at the later age where the surgery can only be indicated, and the recovery rate is, we can say, we cannot reach the 100%, only it's always 70 to 80. For in some women it is only 50%. So they are seeking the medical advice when they are at mostly affected by the any dysfunction. Otherwise they are not coming forward because they are feeling it is common of the part of aging, and it is a silent epidemic. It's always, I say, because whenever even we look into our PT community or the students or anywhere you go, the females slowly speak out, yes, I'm also suffering, I'm also having the same problem. So it is an epidemic, we can say. So it is a silent one, and it's our responsibility to bring out those things to be to the screen, to the light. That's why it's a hidden burden. So it's not only just about the continence or anything related to the pelvic floor, but it's the female's dignity. It will keep you the mobility, because one woman has complained me, whenever I'm sitting to standing, I'm leaking. And whenever I'm walking, I feel something is coming out. So that is, it affects mobility also, intimacy. So it has been a family relationship issue is there, and intimacy, and also the mental health. So they are affected psychologically because of this pelvic floor dysfunction also. So we are not only discussing about only the pelvic floor, it is the whole aspect of the women, which is very, very important, more than our external appearance. So how it is, again, we go in depth of the prevalence rate. It is more prevalent, and the incident rate is from worldwide 1.9 to 46. And I have seen once pelvic organ prolapse, and it is more than 50%. So it is always disabling. What it actually causes, not only the personal problems, it creates a social isolation. So one woman, she is a manager of a company. She came to me. So whenever I'm going for the meeting, I feel like that fecal incontinence is coming, the coughing, or when I'm laughing, discussing, or going into the meeting inside and outside, I'm feeling some fecal incontinence. That urgency to go to the washroom is happening. So she's a very big shot and from the hi-fi background, but it affects. So I'm scared to go for the meeting, or always I prefer to take the online session, or I'm going to rushing into the washroom before attending the meeting. So it always affects some of you in their personal roles, in their official roles. It is social isolation and affect the performance of the task. Sometimes they couldn't able to 100% give their best what they are doing because of this hidden issues, and causes loss of personal and intimate, and many of the partnership relationship or the individual relationship are affected by the intimacy. So talking about intimacy in the later age is always think about a taboo. So why at this age you are talking about this? So I received a patient, she is 40 years of age, and one woman is 45 plus, and they came forward to overcome their dyspareunia because they want to may have a happy and a healthy family relationship. It's not because of the aging, but it's a dignity of a woman to be in the family life and reduce the participation in the leisure. Even one woman, she's very fit, I can even see very fit, she was at 54 plus, and she came, I was in doing go regularly going for the gym and activating in the other extracurricular activities. I have my buddies, everyone. But when I start to involve in some leisure sport activities, I started to feel leaking. So she came to me. So it affects even your extracurricular hobby activities also. So it's having a complex and multifactorial. So we cannot take it's only from the pelvic floor. It has a multifactorial pathophysiology. So when I'm describing, you can understand how it be a multifactorial. So it is always report bladder dysfunction. So it is pelvic floor means it covers the entire incontinence, your bowel dysfunction, pelvic organ plus as well as female sexual dysfunction also. So next you can see it encompasses. So it's not a one entity, it is going to be a multiple entity involving the multifactorial pathophysiology as well as multifactorial etiological factors is also there. So we're going to have, so what, now we'll come to the main point. So we have seen aging and other things. Now we're going to learn what exactly happens in aging women, especially to the pelvic floors. We always know estrogen is there, menopause is there, but how and where it is affected? Because why you need to understand this, thereby you can focus on the rehab very particularized. You cannot go, she's menopausing woman, she is post menopause, she has a weak pelvic floor, that's why she is having this. But I want to go one step more forward into the depth of the anatomy, into the depth of the mechanics of the pelvic floor and the pelvis, so that you can give the appropriate treatment to them. Before that, you can understand the exact cause of this condition. So usually, when a woman comes with the incontinence, 50 plus women, she's coming with incontinence, means it cannot be the reason only she's having a weak pelvic floor. She might have been a hysterectomy, and she might have been some surgical aspect, some fibroid. Even having a fibroid with a bulky uterus will naturally go and affect the bladder and leads to the incontinence. It doesn't mean that you have to have a weak or a strong pelvic floor. Whatever it's, uterus will be bulky like 10 weeks of pregnant uterus and it's going to give a compression over the bladder. It leads to the incontinence. So understanding the exact pathology and the etiology and the mechanics. So when we are studying the knee joint pathology, example, osteoarthritis, we'll not study only just about the causes and the other things of knee joint, but we'll study which ligament was affected, which meniscus is going on, and what about the stability and mobility factors is affected. The same thing you have to understand in this, in women also, and also about the pelvic floors. I never go only into the pelvic organs, your pelvic bone, and the pelvic floor matters a lot in understanding this. So here you can see the bladder and uterus and rectum, it's like a trampoline. So it happens when age goes on, multiple factorial etiological things will affect these game changer you can see. So here I have given some two things, rings I have. So this you can see. So later next slide I'll just cut off the share, stop the sharing and go for the video. So this is a like a ring. This ring will be your like a pelvic bone. And you can see your organs are here, your uterus and everything. So when it is tight and strengthened, toned up, it remains in position and everything goes on function is very well. But when there is a weak pelvic floor laxity, or sometimes you can say because of any pathological or maybe the aging, it affects, it goes to the, so it comes down. So the holding the net position is your ligaments and the soft tissue structures. So if there is ligaments also laxity and also your soft tissue, and if there is any problem with your pelvic bone, and it is going to affect your pelvic organs also. It is not a single entity. So it's, if it is a tight pelvic floor also, the organs will be, it's tighter and not in the optimal position and gives the pain, pelvic pain and everything. So this, when you are considering into the, you have to consider each and every aspect of the pelvic and the pelvic floor. So now before going into the pelvic floor, let's just have a look into the reproductive system, because it has a correlation and they are interconnected. So you have to understand from the top to bottom to clear understand the pelvic floor health. So it is a complex interactions. It always has an impact on the biological, physical, and biochemical process because of the aging. And it is unavoidable fate of aging. So you have to see the function of the cells. So you cannot think only about the structure, not only the hormonal level, but what's happening at the cellular level. So I used to say before I had a webinar about the incontinence, I used to say the smooth muscles and the cellular structures around the urethra will be affected by the perimenopause and menopause changes. The estrogen will go and the nook and corner of each and every cells of the genital system, and it will lead to the weakness. It's not only the structure wise, cellular, tissue level, and also your organ level, and then your surrounding structures. Everything matters. So here you can see I have given a picturization how it is, because we know hot flashes and everything comes in to the menopause changes. But actually, you have to understand what is happening internally also. So here I have given that how the uterus is getting changed in the aging process. So nullipara women uterus is different, multipara women uterus is different, and post-menopause. Even I say the vulva looks different for a 20 plus year old and a 30 plus and a 40 plus and a 60 plus. It keeps changing, and you have to understand when you go for a screening or the assessment, you should be able to recognize and assess these changes. I used to say even the labia major or minor and the opening, everything to be assessed or observed correctly. What is inducing these condition? So the uterus is completely going to reduce in size, it's shrinking, as well as atrophic stages, even it starts from your mid 30. So it's not going to be 40 plus. So I never consider aging in women as 50 plus or anything. I wanted to be careful even at in the late 20s itself. And next you can see the cellular level. You go, is anything voice? Is the changes is happening even in the internal surroundings also, even in each and layer of the uterine cavity as well as in the vaginal canal, it will be there. So here you can see, because when there is a changes in these structures and the weakness of the pelvic floor, it both of the things is going to just exaggerate the symptoms. So here you can see the cellular level changes, the fornix or the vaginal wall, or even the rugae, the folds of the vaginal canal will be undergoing. And you have to note down the one point, the decrease in the vaginal length, that also matters a lot, and atrophy of the labia majora. So they will be constantly having UTI that bothering us more. Even one woman was saying, I couldn't even have my innerwear because I'm recurrently affected with UTI. So there are each and every factor. So what's really causing her? Even the vaginal atrophy to be understood when you're treating the pelvic floor dysfunction for a menopause woman. They will treat only for pelvic floor dysfunction. Think about, she's undergoing vaginal atrophy also, and dryness also will be there. We have to treat coordinately, align with the OB-GYNs, and you have to treat both. Otherwise, we cannot give her 100% recovery. And I have pasted this. So how we are understanding the systematic changes in menopause and in the aging women, you have to know what's happening inside of the female reproductive system. You can see each and every part is undergoing changes. And it begins in 30 plus itself. I can say 30. You can see the atrophic process. That's why when you have the later pregnancy, the more chances for the complication for the women as well as the fetus is more, because you're starting, your organs are starting up the aging even at the beginning of 30s. And here even you can say the reduced in fat, everything is ligament supporting uterus, everything, it has a significant changes. And how we all say estrogen is affecting the pelvic floor, and the other how it is affecting when there is a transition. It's not only the menopause, but if the woman is undergoing surgical menopause, now we can see even at 36 they are undergoing hysterectomy. So we cannot say it is a menopause, whether it can be early menopause or a premature or going to be the normal menopause, or they are going having with the just removal of the ovary or removal of the uterus may lead to the menopause at any age when this transition happens. So we have estrogen receptors everywhere in the body. Especially ovary is the main effective organ which produces estrogen, but other parts, even your adipose tissue, your other peripheral tissues, and even your brain will have the estrogen receptors. What we say, each stages of women that we can see, the estrogen have a lot of variations: estradiol, estriol, and estrone. So at each stages of women, these hormones will be secreted in a different stage. So during this reproductive age, estradiol will be more, estriol will be more, but estrone, which is inefficient estrogen, which has more peripheral secretion rather than the ovary, peripheral secretion of estrogen will be higher, which is inefficient. That's why we'll started to feel the hormonal fluctuations in the later age will be more. And estrogen receptors and estrogen decrease directly, and it will have an impact on the cellular level. How it can impact on the pelvic floor. So when you take the pelvic floor, you have voluntary muscle and the involuntary muscle, and all the voluntary muscles will know with this is skeletal muscle, and involuntary muscle, when you take it, comprises of smooth muscle cells. So these cells will be mostly affected when there is a menopausal transition by the impact of estrogen. It will go first, it reduces the vascularity. So if you take example of the urethral opening, when you go the cross section of the urethra, it will have a smooth cell and a layer which contains lot of arteries and veins. So this vascularity will be reduced because of reduced estrogen. So that will give a very less blood circulation to the genital organs. And here if you see, it will reduce the lower unit tract completely. The lower unit tract will be reduced in the vascularity as well as the cellular support. And you can see the bladder neck activity. So this organs, if it is in place, so the bladder neck is very important. So that support will be in neck act. That means actually it should be in this position. So when there is some changes in the menopause, this bladder neck activity will be extended or it is too much flexed. So that also will lead to the incontinence. So this is the main impact of the estrogen. So another thing that affects the aging is genitourinary syndrome of GSM, otherwise they will refer. This is more common when you attain the menopause, and that also affect your pelvic floor health. And it is highly underdiagnosed. So many things, when women comes with the dryness, and you can see the triad of symptoms because of GSM. So we have to rule out this condition when we treat a aging women, and then we have to start the treatment. If she is undergoing this, she need a multidisciplinary approach. Not we cannot give the complete recovery, so it needs a multidisciplinary approach and also medical treatment and also along with the PT management. It significantly affects it because it is not a single symptom. So next you can see the slide. It comprises of a lot of conditions, lot of symptoms it occurs. It might be a genital, urinal as well as sexual. So that's why it is referred as genitourinary syndrome. So it creates dryness, itching, irritation. So without over clearing of these, we cannot clear the pelvic floor dysfunction. So we have to consider this when we are treating a aging women. So now we are coming into the some clinical relevant anatomy. So we know this weak pelvic floor and the overactive pelvic floor and everything, and it has a both analogy and everything. So before that, what we doesn't know is this part. So this is the main thing which is getting affected in the aging women, the muscles and everything we left out. And then we're going to learn something about this structure, how this are going to get affected, how the incontinence, prolapse or intimacy is affected, what's exactly. So I have just said, make a note how the estrogen affects the cellular level. Now we'll go into the structures that affects. So just for a moment, I will stop sharing the screen and I'll go back to the some insights into the thing. Any questions from the side? Okay. Which one is involuntary PFM? All the internal sphincters, internal urethral sphincters, internal anal sphincters, everything is involuntary. We can train only external muscles, external anal sphincter, external urethral sphincter. But the main play, main role play is from the internal urethra, IUS and IEAS. And if you take external, we have only the train only the external sphincter muscles. So mostly your bladder and anal sphincter will have a lot of involuntary muscles. Detritus are also including. So just I'll show this. So I think my video is visible. So I have been kept this. So before that, we'll just have a view of, because I have just shown the three organs will be placed in position like this. So it is a side view. Your bladder will be in this and your uterus antiflexed and your rectum. So these three will be opening. So can you see this white rubber band I have given? So even I feel very hard to hold. So same pattern, your organs are just get hold by the ligaments and down only it is covered by the levator and we call it as lamb muscles. So usually in urogynecological aspect, it will be referred as lamb. So that is under here. But how the above organs are hold in position? So that I'm going to teach you today. So if you would have attended my previous sessions, that I will usually define most of the anatomy part in detail so that you can understand it very well. So here this is the uterine part, because the ligaments or the soft tissue surrounding the area will be holding on these organs, and all the supports will be affected when your aging process is beginning. So here you can see the uterus is just laterally completely surrounded by your broad ligament, and it is not a pure ligament. It is just a peritoneal reflection. So we cannot consider much about the broad ligament, just structure wise it is holding in the lateral side. And here you can see the more common we will be talking about, the upper part of the uterus is held in position by round ligament. And another one, you can see this, I have kept two things. One is from here, and the two ligaments are from the both sides of the ovary. One is to the uterine cavity. So that is your ovarian ligament. So it holds on to the position with the uterus. Another one to the pelvic wall. That's why I say your pelvic floor dysfunction matters when there is a problem in the pelvic bone also, because it has its attachment. This we call it a suspensory ligament or infundibular ligament, because it comes from the infundibulum of the fallopian tube and it goes and attached to the lateral pelvic wall. And again, down I have kept two ligaments. These are very, very important. And these ligaments are quite nearby to your bladder. So if you are having incontinence, you have to think there is a laxity in this ligament will lead to the cystocele as well as to the incontinence also. And this is, we call that as very important ligament, that is McInroth or transcervical or cardinal ligament, because this hold the lower part of the uterus in position and also the supportive other organs. And another ligament is there. So we, both the sides it will be by transcervical. Another one is pubocervical. So in front, it will be pubic symphysis will be there. It will connect to the pubic bone. So it will be held in position. So this is referred as cardinal, transcervical or McInroth, which is very important in position. And your pubocervical ligament, and another one I have kept is golden color. This will go at the back. Very, very important, your USL. Uterosacral ligament go and attached in the sacrum. So that's why sometimes if you have a pelvic organ prolapse, the women will be complaining of the back pain, low back pain or a pressure in the pelvis, because these ligaments will be laxity. Okay, so we have to understand these ligaments. And another important point you have to understand is this USL and your pubocervical ligaments. When we are studying these ligaments, you have to remember the fascia also, because it goes along with this muscle. One is pubocervical fascia, and then other one is endopelvic, three fascia. So I used to remember ligaments and your fascias are very important when you're considering pelvic floor. So one is your, so when you have this part is like this, the endopelvic fascia will be covering the entire part of the your organ. Sorry. Okay. So if it is in the position, endopelvic will be covering the lower part completely. So I'll be showing in the slide. So completely lower part of the endopelvic fascia. So if there is any laxity or injury happened during the birth, childbirth, so that will lead to the instability or instability of all the pelvic organs. And again, another thing, arcuous, that is we referred as ATFP, arcuate tendinous fascia of the pelvis. Very, very important. That supports, because I have this paper, I couldn't do this. It's completely surrounding the front part and holding all the three organs in position. So, however, that's why myofascial release are considered when there is a problem in the pelvic floor. So, these ligaments and the fascia are very important. And then lastly, that is by the levator ani muscle and then your puborectalis. So, these are the, when you come in terms of external anal sphincter, so that time you have to remember your external anal sphincter muscle will have three parts. Superficial and the deep or the subcutaneous. It is not a single part muscle. It is a three-part muscle, even your external sphincter. So when you're, before treating any women, you have to understand this pathology. Now just, I was telling about the ligaments. Think about when a woman undergone hysterectomy with a bilateral oophorectomy, TAH with BSO or LAVH, anything, laparoscopy or anything. The entire uterus will be removed, only the vaginal stump will be kept over. So what happened to these ligaments? So when a woman, 50 plus women comes with the incontinence or a pelvic, not organ prolapse, vault prolapse they will be having, not the organ prolapse, where she comes with the incontinence, how will you, just you have to think about the ligaments, what happened to this ligament? These ligaments will be dissected and ligated. And when they are removing ovary, they except the infundibular ligament is preserved. The other ligament will be completely cut down and taken away. So that when I be handling any hysterectomy patient, I'll be asking what kind of hysterectomy you have undergone, because I have to think about the soft tissue structure that support what be the uterus was having. Now everything will be lost when the uterus is removed, and your uterus is and the ligaments are hanging without any stability factors. So where the stability is only from your levator ani muscle and the puborectalis, there all the ligaments are hanging out. It just dissected and ligated. Bleeding should not be there, so they'll be preserving and just burnt out the tissue level, and only your levator ani muscle has to support now. So all the hysterectomy patient, especially TAH, they will be undergoing the vault prolapse because of the weakness of the pelvic floor muscle. So that's why I'm teaching the ligament part as well as the fascia, which is very inevitable anatomical part you have to learn before handling the aging women's. And I have shown here also. And before that, you have to understand, because I'll be telling about the MRI images, the levator hiatus, because how we are having a diaphragm hiatus, we will be having. So think about, this is the pelvic floor, and I have said 3 organs are here. So this is, we referred as levator hiatus. So this will be in front. So you can see this will be in front, and this we call it as levator hiatus opening. The hiatus means it has opening, and this high levator part will have 3 openings are there. So if any opening enlarges, everything is going to, laxity happens and everything will comes down. So before treating any pelvic floor dysfunction, you have to remember each and every aspect of this and then proceed with your rehabilitation part. So now we'll go into the slide. Yeah, I'll be answering the question. So we are running out of time also. Please, ma'am, if anything, you just tell me when I have to complete it. So this is, I have given, what I have shown is, the thing is here. So LME is your levator earning muscle. Sorry, this is longitudinal. So this you can see the muscle, when you see from the sideways, these are the structures which holding these organs in position. And especially if you look, the ureter part is near this. So if there is, the laxity happens not only in the urethra, the supporting structure happens, it will lead to cystocele, incontinence, and pelvic organ prolapse. And then if everything is lost, there will not be any libido. So that also will be affected. Okay, so the next part, it's not moving. Okay, so here I have said pubourethral ligaments. Can you see the structure? I will take the annotation part. So here you can see the green color. So I'm also having green. So here you can see this is your ligaments. All this gray color structures are your ligaments. And this is your arcuate tendinous fascia. And this pubourethral ligaments that hold the pubic tube urethra. So if this ligament will help in the urethral closure and the open. So if these ligaments get traumatized during even childbirth, or even if you're undergoing any invasive surgeries near the urological part, that also affect this. And then you can see this uterosacral ligaments also here. So these 3 ligaments are very, and you can see the CL, cardinal ligament. So these things can be get injured or laxity happens during the childbirth also. Assisted vaginal delivery. Don't think that it's only happening with C-section or anything. So it happens when not, vaginal delivery will not going to preserve this. During vaginal delivery, so if they are using vacuum or any other supportive methods, it might be harming these structures and it might be expanding. So I'll give you the picture later how it affects from the childbirth to till this year. So this you can see where you have to remember everything of the soft tissue structures surrounding this. One minute, I'll rub off this so otherwise it will be interrupting us. So next to this, I have given us 3 levels. This is very important. Dr. John O. Delancey, he was the one who gave this 3 levels of vaginal support. He's a urological and pelvic floor surgeon. Very old he is, but his uh, contribution to the pelvic floor is very remarkable. And he was the one person who did a remarkable work in pelvic organ prolapse management. Still he is doing, you can read out, I have just given his article also, you can read. He will be doing a remarkable what is research in just treating about the pelvic organ prolapse as well as in the fecal incontinence. So how I said, it's like a 3 level of support. So when we are studying the pelvic organ prolapse, we will be studying on this basis at the level of external outside and in the vagina and inside the vagina. So there are 3 levels of support. So first one is your level 1 is uterosacral ligaments, level 2 is endopelvic fascia, and level 3 comes to your levator earning muscle. So these 3 levels of support to be very stronger to have your pelvic organ in position. So he's the Dr. Delancey. So he was I have given the study. You can just go through. It is a recent study, 2023 study. So he has made with the ultrasound imaging as well as MRI imaging to study about the pelvic organ prolapse mechanics behind it. So it was a very good study. You can just read over it so that you can have a good aspect of understanding the pelvic organ prolapse in the aging women. So he was aging is also associated with not only the hormones and the structure, more than that, he's going in depth. The smaller and weaker levator animals, it is getting shrinked and weakened and larger, but genital hiatus has been become large, widened because of the process, childbirth process, and other things. Even if when you look into this, you can see the nullipara women also how they are affected. Not only the women who undergone childbirth, even others are possibility of having this. And larger levator bowel volume. So you may be confused where is the levator bowel. So I have shared the images here. So here they have compared the young and the old, how it looks like. So first one is your sagittal. So this is a cross section sagittal view of the levator in a muscle area. So it has been become, you can see wider area in the down part, and that is become larger. And the second one is levator bowel volume. The volume has been increased. And this is your levator hiatus. So what is mean by PICS? Pelvic inclination correction system. So they'll be doing in the MRI study. So you can see this young levator plate is like this. Sorry, hiatus, that opening part is like, here you can see it is V shape, and here you can see it is U shape. So when you after aging happens, everything becomes laxity, and it has been. So if you take a rubber band, if it is loose, it will be become longer, lengthened more. So that's what it's happening. We cannot think only about the muscles. Here you can see the entire part is getting widened. That's why women's are tending to get more prone for the dysfunction in the later ages. So when the rubber band is slightly moving apart, you will not see anything. But if it is more lengthened by the childbirth process, or if you're giving recurrent weightlifting or recurrent abnormal, what we can say, not in the right improper posture, that also going to affect all the structures. So next thing we again went little depther into this. What is that V and U? So V shape vulva, you can see this entire part. So this part will be a, so here you can see this is urethral opening UVR. So this is urethra, vaginal and rectum. So these openings will be maintaining the V shape that shows the intact structures as well as your pelvic floor muscle also. But in case of the older women, you can see it goes the blue color shading part. It looks like a U shape. That means laxity was there. And sometimes because of the 3rd degree perineal tear or 4th degree perineal tear, or sometimes we call it as VIACs, obstetric anal sphincter injury, this U shape will be happening. And next picture, he was when, so I had an opportunity to attend the Dr. Delancey lecture. So he was teaching that the incomplete covering of the levator muscle will be seen in the women who undergone the 3rd degree perineal. Usually it will be covering your 5 to 7 o'clock position. So there will be some muscle will be injured or traumatized birth, or any perineal tear extension will affect the continuity of the levator and a muscle, that will lead to the prolapse also. So when there is a prolapse, there will be more chances for the incontinence also. Here you can see they have again studied depth of the pelvic floor in the aging women. So here, so this was the lecture I attended with Dr. Delancey. So he was shown that this was the delivery, the crowning stage. And here you can see the first day of delivery, even first day itself, you are able to witness the prolapse. And even after 6 months, it was there. But do the women are approaching the treatment immediately? No, it was negligence was there, because after some days, 6 days, it will be slightly reducing, and sometimes it will be go off. So the mother or the women will never consider about the symptoms, and she just negligence will be there. And you can see after 6 years, still the prolapse got worsened, and the same women come back for the pelvic organ prolapse. So it doesn't start from the later ages, but it starts from the day of your delivery. That's why I say your delivery is not a one-day show, but it's going to affect your future life also. Extension of your second stage of labor, the mode of delivery, it's going to have a more impact on the pelvic floor. I have seen in many influencers or in the social media, they feel very proud to say, I was undergoing labor for 48 hours, 52 hours, and it was 2 to 3 days I was in pain and successfully completed my vaginal labor. So it's not, don't feel proud about it, but I can say, I can assure them 70% of the same women come back Some technical error from my side. Sorry for that. I'll be continuing. So this problem with my Wi-Fi connection. Yeah. Okay. So we were telling, so the rehab should be begin from the day of delivery. So she came with a rectocil and she had a very smooth labor process. Then why? She had a birth pool delivery in Bangalore, and because of the birth pool, because we cannot give complete perineal support in the birth pool delivery. So there was a third degree perineal tears. Immediately she was taken out and suture was done. So that's why she was feeling the immediate after that, just even 6 weeks after delivery, she started to feel the symptoms of the rectocil, and she started some following the YouTube line to do the exercises. And I was asking, what are the exercises you are doing? And she was telling some few kind of exercise along with the squat. Deep squat was in added to that. So that's why I say analyzing what has happened to the mother is important before prescribing the exercises to the women. So deep squat will be aggravating your prolapse symptoms. So that might have been aggravated her symptoms. Then I identified, and then we have made up a correct protocol for her. So what are the causes? So we have very short of time. So causes, always we know what are the main causes behind the pelvic floor dysfunction. So I'll just go to the important aspects. Your congenital structure causes also will be there, and the happenings in your other stages of delivery process and the aging process. Even you can see some people will be having chronic cough. So that persons also will be having this pelvic floor issues also. So we have to treat the underlying factors also. Women came with the incontinence. She was continuously coughing in between when she was discussing with me. So I said we have to rule out this first, and I have taught her the knack technique. So without the knack technique, I cannot give the complete recovery. At least I have to, because she's 60 plus women. At least I have to give her 70% of recovery back. So we have to think about the exact cause behind, and almost every causes, not only the obstetric causes. So I said there is no exception of cesarean mother will not have the pelvic floor dysfunction. I used the effects of pregnancy will be same for both the vaginal delivery women and the C-section women in common. The the enlarging uterus and the growing fetus will have an impact on the pelvic floor. So that's quite common for both the mode of delivery. So there will be some problem in the weakness will be in the pelvic floor, though the mode of delivery may be different. So that has to be considered. Twin pregnancy, and then if the baby weight is more, macrosomia, everything considered to be as the obstetric causes. And the deliveries, the proper perineal support during the labor, and the degree of tears that happen in the intrapartal stage, and then menopause and aging. These factors ought to be considered more. And then what are the things, other things that any pulmonological causes, any neurological causes. So that has to be also focused on it. So what are the pelvic floor? So we'll see. Everyone knows about this. Just I'm going to the outline of that. So incontinence, anorectal, as well as the pelvic organ prolapse and the female sexual dysfunction will be there. So when there is a urinary incontinence, you cannot mean that they will have only SUI. SUI is more prevalent, but I'm seeing that urgency, frequency is more common because of the overactive bladder. So recently, these kind of things are more common because we are controlling the urge for a long time, and that affected the involuntary or detrusor muscle. Detrusor instability is more common nowadays in the aging women also. And so this fecal incontinence. So they will say, I have delivered 3.9 kg baby successfully, 4 kg baby. So I can appreciate them, but you have to think about when your body is cooperating with the normal labor, go with it, but don't force it for the normal labor. If you're doing that, you are not spoiling, you're not going to celebrate that, you're going to celebrate the 1 day process, but it will have a more impact. So I have seen a woman who delivered twins, one is 1.8 kg, another one is 2.1 kg. She successfully delivered vaginally. And next day, they called me to meet the patient. She was only 21-year-old, very young girl, and she had this fecal incontinence the next day. So that's why I say your delivery process have a more impact. Don't force anything. Just go along with your body response. That's matter a lot. So pelvic organ prolapse, we have lot of variations out there. So we have to consider whether it is a anterior compartment or posterior compartment or from the middle or from the vault prolapse. So you have to know, identify which one has happened. And here this is the vault prolapse, which is commonly seen in hysterectomy patient. And here, bowel dysfunction in terms of constipation, that also more common nowadays in aging women. And even it starts from the 20 plus. Some women, they are starting after the delivery also. So another, now this we are seeing in Bangalore more commonly in 50 plus women's. And I received a woman of 27-year-old also. It might be a structural defect or might be the aging process. They are confused incoordinated pelvic floor. So they will be having constipation more common. Constipation will lead to incontinence. So when you see 60 plus women continuously holding the anus in position. So even I couldn't even insert my finger and assess for the muscle power. So that tightness will be there. So this synergic pattern is more common nowadays. And we have to, because of the weakness to the other group of muscle, led to the tightness of the another group. So we have to rehabilitate all the things, not only considering only bladder muscle, only incontinence, only that vaginal muscles or only the anal muscle. You have to think about the whole deep core rehab. So then only we can overcome these kind of conditions. And female sexual dysfunction. So you can see there are 4 categories of sexual dysfunction will be there, but more predominantly we can see all the 4 in the aging women. So sexual pain disorders, so these are related with the psychological as well as structural. So we receive even after 2 baby delivered women coming up with the dyspareunia, female sexual dysfunction will be there. Or later ages, they'll be having vaginal dryness, lack of lubrication, and loss of libido will be there. So that lead to the sexual dysfunction. So we have to find out desire disorders. We need psychotherapy support because if they have any misunderstanding in their family life, as well that lead to the sexual desire and arousal, that we also play an important part when there is superficial pelvic floor muscles like bulbocavernous, ischio-cavernous muscle and your superficial transverse perinealis muscle. They play an important part in orgasm function. So that muscle during the delivery process, these muscles are completely affected. So if you see the vulva, the muscles will be here. So episiotomy will be given here, right? Mediolateral episiotomy. When it is given, the bulbocavernous muscle is here. Your ischio-cavernous muscle will be coming up here. STP is here. Everything will be get weakened by the episiotomy procedure. So that also lead to the orgasm, lack of orgasm, as well as libido also will not be there because of the trauma. If there is, why it is occurring in young women or 20 plus women, those who are nulliparous, they will have endometriosis or any other infection or inflammatory process that's happening, recurrent bacterial infection or vaginal infection will lead to the inflammation, and infection process will make the pelvic floor muscle to go tightness. So how this pelvic floor dysfunction impact the women's life? Just I have given a only a small outline, concise form. Sorry, this is a typo error, physical. So it might be affecting their mobility and fall risk. They'll be, so the women was complaining 60 plus. I'm always I'm just sitting near the washroom so that I have to walk. I'm feeling very hard to walk with the OA knee. So that's also happened with them. So clearing this pelvic floor dysfunction and maintaining the pelvic floor health is important to consider in terms of MSK things also. Psychological, so as I explained earlier, it has to be bring out a lot of anxiety and other things, social and economic. So they might be in the home, they may not be working, workplace may can avoid during this these kind of issues. So reduced work productivity, especially after some time, they may not go for work. So that also affect them and they may have to undergo surgeries that also lead to some of the embarrassment or anxiety in these women. So how can we detect earlier? So I have given this women. So far I have treated the women. So I feel always struggle to bring out the answer reply from them. I have to ask too many questions to bring out the exact cause from the mothers or the women's or even from the girls. They don't speak out very easily. So I always prefer to give simple kind of questionnaire. So each condition will have a many questionnaires are there, so that we can take up us before consulting or during the time we can give the questionnaire to them. Encourage open conversation. That means no yes or no question. You have to give an open-ended question. So you have to make the patient to speak about their experience, what they are undergoing, so that you can understand the patient very well. and shift the mindset. So sometimes I'm undergoing this, but it is normal. So they used to say. So you have to just say to them that these kinds are not normal. So then they will. So I was suffering with this for a long time. Is it not normal? So we have to bring out shifting that kind of mindset is needed and encourage women to speak up. So we need to make the women to come little earlier, not to wait the late aging time. So whenever they comes, even she comes in late 20 or 30 plus, make the women. So if she comes with a sacral dysfunction or a low back pain, ask about the pelvic floor health also. So how come you are opening up this conversation will help us to detect them very earlier. So always when you're assessing them, get the confirmed consent from them. Always it should be a written consent. And if they request chaperone to be, because many of them they need chaperone, but they are not accepting. So partners can be in, but always when you're so we will be providing in the consent chart itself whether they require chaperone or not. So we'll have a small cubicle, not well lighted, minimally lighted, and you have to expose them very minimally to have a pleasant and comfortable environment. Explain the treatment plan and proper documentation is required. They will be asking how many times I have to do, how which position I have to do. So your documentation matters a lot to make the patient to understand their condition very well. Educate them what their problem is. Examine with their concern and comfortable thing. So first visit, the women has to feel the comfortable and confidence in you. Then only she'll come up for the follow-up. So when I meet the students or the clinicians, they used to the patient are not coming for the follow-up regularly. It happens in all women's skin condition, especially in case of pelvic floor, because they usually come without knowing their partner or the family members. Most of the sexual dysfunction I received, they said our in-laws doesn't know about it. My mother doesn't know about this condition. So they'll come in the weekend, they come in the late after the work. One woman, she always completed her, she's assistant manager in bank. She completed her work and come back in the Saturdays. So it's always, we have to think about it and we have to make a comfortable, convenient, and a confident session for them. So next session or the proceeding follow, they will come for the regular and they will open up. They'll start to open up everything what they are suffering. So I have given the assessment. Almost covers whatever we are seeing in the pelvic floor assessment. The pelvic floor assessment to be in detail and make sure you are giving that assessment part to the patient which they can understand. So now they are all our Google scholars, I can say. So some patient they will sit and ask each and every line from me. So I will explain in the term because they think that we are writing out something which is very scary for them. So I'll write down which they can understand. Some privacy things we cannot write it down. Some will be requesting doctor to don't please write down this. So one woman was she's with the primary vaginismus. She was traveling to one place to another. So when I have referred with the letter, so it was a privacy matter because she's going to show it with the Air Force security also. So I have written she's undergoing gynecological condition, not elaborating the condition. So some things to be hidden in case of assessment, which you can notify for your personal use, but write down the needed required things in the assessment chart and which patient can also, at least we cannot explain to them completely, but let them know what they are undergoing, what they need, and what your treatment plan, because they will ask it's going to be 3 days or 3 weeks. We cannot have make a complete protocol, but you can say what you are doing and what they can expect, how long the treatment session may go, and how will they recover, what else needed for their recovery. So we'll see just a 5 minutes, ma'am. I'll be completing it. So preventive, you have to give the proper pelvic and pelvic floor. So I never see your pelvic floor, other muscles are attached with the pelvic bone. So it has to be surrounding both aspects to be continued. So what is adequate antenatal internatal care? So yeah, I used to say when you are having the antenatal class, include the pelvic organ prolapse awareness also. Teach NAC technique, try them to go for the understanding of the T activation. This will come just you can prevent a lot of things in the future. So you cannot teach them when they are fully in the third trimester, but when they are coming in the first trimester itself, teach them the pelvic organ prolapse awareness and NAC technique because that time they can easily do perform. But with the enlarging belly, it's very difficult for them to perform. But you have to teach them so that they will continue very easily in the postpartum period and postnatal rehab. So here I have given the picture. It's not only the diastectomy, it's not only the pelvic floor dysfunction. You have to focus on the entire deep core, your diaphragm, pelvic floor, anterior abdominal vessel, as well as your deep back core muscle. Example, your multifidus, quadratus lumborum. I used to say all the thoracolumbar fascia, everything to be focused. And what is the general measures for ADL? I used to say they are doing exercise for a 1 hour, but what they are doing in the other 20 plus hours, that you have to focus on. The house ergonomics and the maternal ergonomics. And I'll teach toilet ergonomics, and you have to workplace ergonomics. You have to teach them, because remaining 20 plus hours they are spending in their workplace or at home. So even when they are lifting any heavy weights, teach them, take a breathe, or don't breath hold. So we have to give the instructions for the daily activities. That is, we refer to core pressure techniques. So we have to educate the young women, antenatal, postnatal women, not when they are coming as an incontinence patient. That then cannot be give a good result. So it starts from the earlier. They have to know earlier and speak up earlier, so that we can recover them better and prevent many complications. And awareness, like I can see many breast cancer awareness camps, PCOS, now we can see breastfeeding camp, but I never seen any pelvic floor screening camp. So we have to bring up those things for the women. At least physiotherapist and OB-GYN, urogynec have to combine and start the screening camps, so that women start to speak up earlier. So this we have conducted in the Bangalore street in the early morning. So even I can say from fifth standard to old age women, they came forward and look into it, and they were asking many doubts regarding that. So people are expecting us to open up. So if we open up, they will also start sharing their intimate issues also. So conservative, it has to be provided only to the asymptomatic women in case of POP. So sometimes symptoms which can be within the treatable, we can go with the conservative. So example, I have given pelvic floor PT, pessary, estrogen replacement if she is a menopausal woman, and improvement of the underlying. It might be a pulmonology or the neurological factor that has to be improvised. And core pressure management techniques. So NAC techniques, so always I'll say the pre-bracing technique for pelvic floor. So he's the Dr. Miller. He only demonstrate the NAC technique. He's an engineer by profession and doing research in pelvic floor. You can see many articles from him. So he was the one who invented in 1998 the NAC technique, which will be very beneficial for the incontinence as well as for the pelvic organ problems. This core pressure management techniques is mandatory for incontinence as well as for the pelvic organ prolapse. So you can see the girl is doing side laying SLR. Okay, so can you see her mouth? It's my student only. Now she's a PT. So she's breathing. So you have to integrate the diaphragmatic breathing when she's doing exercise also. That's why I've given the picture. She was beautifully performing that exercise. So not only performing, how you are coordinating with other muscles. So hip SLR is going to work out your hip flexor and also the abductors, but you're integrating with that with diaphragm as well as the pelvic floor also. So you need integrated breathing pattern, household activities as well as in the exercises also. Okay. So I have given this example of your pelvic floor PT. So I have given this integrated core rehab. This is very much needed. So I have just outlined all the treatments what we are providing in case of pelvic floor dysfunction. So this is a video. I don't know whether it is playing. I thought that I have not included this, but included. So usually I'll have this video description in my laptop to explain to the patient. If you say verbally, it's very difficult for the women, especially who are aged, they are difficult to understand it. So I'll explain in the video, as well as I'll have the mirror in my assessment table so that the patient can understand it. So they have to not only contract, not the endurance training, but correctly contract. When they have to contract, when they have to relax, when they have to actively integrate the pelvic floor exercise, when they have to relax the pelvic floor, that they have to have a good knowledge. It's in your hand to explain to them and to understand. So it's not just a pelvic floor muscle exercise, but it has to be integrated with the household activities as well as the workplace, as well as in your exercise session. Example, they have to relax their pelvic floor when they are defecating. They have to contract when they are coughing and sneezing. They have to actively do the breathing and the pelvic floor relaxation and squeezing when they are performing in the gym activities. And when they are lifting weights, completely let go. This both the relaxation is same. So one girl, she's 24 years doing regularly weightlifting, deadlift for 25 kg, 25 to 45 kg she lifts. She came with the incontinence. So it's not, rather than treating as a weak pelvic floor, I was assessing her breathing pattern. It's completely wrong. And she was not taught about the breathing pattern at all in the gym. So that's led to her the incontinence. So these are basic pelvic floor exercise I have integrated with the pelvic bridging. So as well as you have to make them to align with the jaw, your pelvic floor and your breathing pattern. So it has to align your jaw as well as your foot. So even example, if you take the bridging, so when they are doing this bridging, I usually place the ankle in the right position. And when they are doing bridging, the knee should not come apart. It should be closely placed, ankles to be in position, and the hip should be in neutral tilt. So you have to check down all this and then do the bridging. Otherwise, it's not going to benefit your correct target of the exercises. And this beautiful images from the pelvic floor muscle team. So it's for the tight, and those who have sometimes some women will have tight pelvic floor. That's pain may be there, sexual pain. So for them, we'll be giving this as a instructions for them. So electrotherapeutic management, as you know, we are treating with the ultrasound, IFT, and biofeedback, and we have individual incontinence stimulator. So if I have Q&A session, I will show I have all the equipments with me. So there are specific incontinence stimulator is available for the treatment, but I prefer electrotherapy management only if the muscle power is 0 to 1. Otherwise, how much you are actively inducing, that much the rehabilitation will be good for the pelvic floor muscle. So vaginal weights and dilators and bond if there is a pelvic pain. And most of all, I will end up with a behavioral training. I will attach a sheet how to have follow the toilet ergonomics, how they have to control the urge in the efficient manner. So that's matters. Giving only exercise sheet will not recover because they are aging. They are undergoing lot of things inside. So you have to make them rehabilitate as a whole, not only in the aspect of pelvic floor. Okay, surgery when it is indicated, when there is completely failure of conservative management, and they will have urine will not come out at all, and bladder will be bulging, constipation will be very heavy, and the rectum will be bulging out. And this is abnormal uterine bleeding or dysfunctional uterine. In these cases, they need surgical intervention. We should not, as I'm a pelvic floor PT, I want to treat them. Some stages they need the treatment surgically, so that we have to refer them at the right time, understanding their problem. So my bottom line is break the silence and restore the dignity of the women. So healthy pelvic floor means it's not free from the dysfunction, but it is in spite of your dysfunction, you have to come with the freedom to move, laugh, and travel. That is the aging with dignity. So it's time to bring this hidden burden to the light. Okay. Thank you for providing me this opportunity. So you can start with the question answer session. I'll answer the questions. I went back. Yeah. So previously I was having few questions. I missed out. Does really ligaments dissection causing back pain? Uterosacral ligaments example. It will be. Even if they are taking one ovary, you can feel that the adhesion will be more and you will have the pelvic girdle pain will be more sometimes, but you have to check for the other things also. So when I receive any back pain patient, I usually check for all the biomechanics aspect as well as MSK and then pelvic floor. So what kind of hysterectomy they have undergone, that also you have to consider. So if there is resection of the complete hysterectomy is done, then you have to uterosacral ligaments will be affected, and you have to think about the infundibulum ligament also. So there will be lack of support and dissection. There are two terminals of dissection, ligation. So dissect means they'll completely cut down, and sometimes they will ligate and kept it aside. So what they have done, that's why I say keep reading the surgical notes and understand what she has gone through, and then proceed with the protocol. And then you have to understand laparoscopy is different and your abdominal opening is different. And what the thing you have to understand, the hysterectomy is, when you are doing hysterectomy, there are more chances for ureter injury. So that's why they'll have in ureter injury as well as nerve injury. I have seen one woman who undergone hysterectomy. She had a lifelong urinary incontinence. She was with the catheterization, the bag, urinary bag, almost she was carrying everything. Why means, I don't say it is the problem with the surgeon. If you just view a hysterectomy surgery, it is like a major surgery, like how you're doing the knee above knee or below knee amputation. Because I have witnessed when before they removing the uterus, there was 24 artery forceps was inside, I don't know where they have ligated, where they have just clamped. It's very difficult. So they have to know, they have to clamp the, what we can say, ureter. So they will just clamp the ureter, and other nerve should not be clamped. So they will just differentiate which is nerve, which is vessel, and which is ureter. And all the vessels coming from, see, this your uterus, all the arteries will be at the lateral side. That's where your menstruation is coming. Lateral side will be completely, vessels will be there. So when they take out the uterus, no, they have to just clamp all the arteries correctly with the artery forceps, not with any other thing. So and then when you take a clamp, no, they have to be go very correctly. And they, once the doctor was explaining to the surgery, I was listening to the lecture, said they will listen to the pulsation, so they will understand that is the artery, and they will check for the nerve should not be clamped at all. And then ureter, they will see the pulsation movement of the urine, so they will see, they will move aside of the ureter. So if any of the things that happens unknowingly, then it's going to be affect, lead to your wall prolapse or your pelvic floor dysfunction, disturbing other abdomen control like empty space. Yes, it will be. That's why the patient will be going gastritis more. And it's not a huge organ, but if there is, they have with the fibroid bulky uterus, it might be occupying the more space. And you can see, well, that's why vault prolapse is happening. And adhesion. The worst thing is the scar site adhesions and the intestines will be more affected. I have received recently one patient with a GERD, GERD, and gastritis, and bloating is more common after that. They will be seeing, during having fibroid will lead to bloating. But after that, also sometimes after removal of hysterectomy, also they'll be having this gastritis problem and other things. And you can see even your, if they are eating more food more than a small plate, then they will have severe bloating, because the surgical scan, if you think about, the uterus is like this, the stump will be from the vagina. Before they used to leave the cervix, but now they are not leaving the cervix, because later on they are getting cervix cancer, so they are leaving only the vaginal stump. So how the stump is healed, whether it is having adhesion with the adjacent organ in the intestines or with the rectum, that matters a lot, because I have seen after hysterectomy, one patient had rectal endometriosis. So the from the scar, endometrioma developed. So we have to think about, it will be affected. But I can say, if you keep moving at the right, so I'll be teaching the first breathing pattern. And they will often have constipation, because it will affect the food movement in the intestines. Can you explain rehab for wall prolapse? Yeah, it's same as the thing, like, but they have to So we are just continuing wall prolapse, no? So it has to begin from the day. So that is very important. If you are delaying, then it will be producing. So I said reconstructive surgery. The same way, if the women, the 45 plus women is undergoing hysterectomy, means we have to check the pelvic floor muscle power before. If she is having underactive pelvic floor and she is undergoing hysterectomy, later on she will be led to prolapse. Even once I took the hysterectomy rehab, I said, if the pelvic floor dysfunction is before the surgery, then she's going to have the wall prolapse and the incontinence for sure. because it's like a reconstructive surgery only, because of the surgical procedure, the soft tissues will be losing the laxity and it will lead to the wall prolapse. So it's mandatory to have the pelvic floor rehab before itself, especially those who have bleeding, fibroid or dysfunction uterine bleeding. Other people's, that's why when in the book it will be given pre-assessment and pre-PT management to be done. That if that means, then we can prevent the wall prolapse. But you can see when I attended a urogynecology conference, some of the surgical techniques also leading to wall prolapse. So they are giving their best to remove these kind of complications. So they say total abdominal hysterectomy is more causative for wall prolapse. So now they are increasing the incidence of laparoscopy assisted vaginal hysterectomy, because total abdomen it completely excising, it creating lot of empty space and lot of injuries, soft tissue injuries are happening. So that's why they are avoiding, just in case of certain cases only. Because example, if the uterus is bulky more than 12 weeks, that much bulkiness, that cases only they are taking for total abdominal hysterectomy. Other patients, to avoid the wall prolapse, they are coming back with the laparoscopic assisted. Does lap procedure also weaken? Yes. Bloating will be more common, they used to say, because they will, before going into the laparoscopic approach, they will inflate the abdomen for their easier approach. That later on it will affect, see, not the muscles, but it affects the intestines later, and bloating will be more common after laparoscopy. That's why I say, if it is needed, go for the surgery. Otherwise, try to go conservatively. Not the abdominal muscles, I can say, because very less the scar, when you think about scar, laparoscopy will have a less effect when compared to the open. Open, you have think about your scar is quite larger like C-section. It will affect the abdominal muscles. But when compared to the laparoscopy, it is very less. So any other questions I missed out? Earlier I had, please anyone, if any questions I missed out, please let me know. I have said involuntary muscles I answered. Some questions I have seen earlier. Can anybody, if they have question, you can ask me. Thank you. Yes, Vijay Bharati ma'am.
Yes, ma'am.
Yes.
Thank you so much, ma'am. We extend our sincere thanks to Dr. Jasmine Flora, ma'am, for her informative and engaging presentation on this special topic. We appreciate her expectance and willingness to share her knowledge with us, particularly a wonderful model presentation that facilitated easy understanding. We thank all the participants for their enthusiastic participation, which made this event a success. We request that you to all connect your support throughout the series and share the details with your friends to celebrate World Physiotherapy Day in a meaningful way. We also thank our digital team for this seamless technical support. Thank you everyone from the Tamil Nadu team.
Thank you so
Thanks a lot. Thank you very much. Especially thanks to our resource person, Dr. Jasmine Flora ma'am, and IB Women's Health Tamil Nadu to celebrate the World Physiotherapy Day in a very unique way by spreading the knowledge. Thanks to everyone. I just request everyone, please subscribe IIP India YouTube channel and other social platforms, the Facebook and the Insta. Thanks a lot. Thank you very much.
Thank you for everyone.